Thank you, Leanne. Thank you very much to the organisers for the invite. So I'm going to be speaking to you about intraoperative strategies for pain-free, minimally invasive surgery. I do have the following disclosures. Importantly, I'm President-elect of ASA that Julie's already mentioned. I'm a founding board member of Poki, which I'm going to talk about quite a bit in this talk. So ASA, for those of you who don't know, is a multidisciplinary society aimed at education around enhanced recovery. And it's really done this in partnership with Poki, the Perioperative Quality Initiative. And the consensus conferences that Poki does are a little bit different to the ERAS guidelines that you may have seen, and they focus on specific elements of enhanced recovery in perioperative medicine, such as analgesia, management of the patient with chronic opioids, nutrition, blood pressure, post-operative delirium, and all of these are available on the Poki website there, www.poki.org. And the other thing that we've done with Poki is made all the infographics freely available, owned by Poki on the website, so they can be used either in manuscripts or in your hospitals. And I know Julie showed a couple of these, but I'd really like to highlight some of these infographics. So this is the first Poki that we did, which was a couple of years ago, focused on a variety of topics, and say a lot of the data I'm going to show you today and some of the statements from the analgesia group. And that produced this infographic that Julie showed you. As I say, this is freely available. We use this in our pre-anesthesia testing clinic. I think it's hugely important, so I'd like to dwell on it for a second, because a lot of patients say they want a pain score of 0, and I try and use this infographic to show that we really want to optimize your pain. We could give you more opioids to make your pain score 0, but if you've got a pain score of 3 or 4, you can function and you have minimal side effects. That's a good place to be, and I don't think we can emphasize this enough to our patients. It's probably the most important thing we're going to do as we're trying to talk about minimizing opioids. And you've seen this slide as well already. At the top there in the green, the education piece. Then in all our patients, we'll do round-the-clock acetaminophen, nonsteroidals, and gabapentinoids whenever possible. And then there's various different blocks and techniques that you can try. So there's epidurals, and we use those mainly for open cases, and there's Taplocks, IV lidocaine. There's an increasing number of blocks now, QL blocks, ketamine infusions, a variety of things that you can do. The most important thing I'd like to emphasize is opioids are not on here. And there's a dirty little secret that you have to know about your anesthesia provider. Anesthesia providers in that chair love giving opioids. And we learned this the hard way because we tried to minimize opioids, but we didn't specifically say this. And CRNAs or residents, when they sit there, will be watching what you do. If you get a little bit of stimulus of that peritoneum, boom, they'll be there with 50 of fentanyl. And this will happen repeatedly throughout the case, so 200, 250 of fentanyl will be given. So we now very specifically in our enhanced recovery pathway say no intraoperative opioids unless you contact the attending anesthesiologist. They hate contacting the attending anesthesiologist. That's been very effective in stopping opioids being given. So which technique should you use in your hospital? Well, I think this is a nice little infographic about implementation, and the important thing is interpret evidence in the light of the local experience. Which block is going to be right for you? Which technique depends on your patient population, it depends on your hospital, depends on the acute pain service, how that works. It's going to be different from population to population. So the important thing is to look at the evidence and then interpret it in the light of your local experience. The other general point I'd like to make follows on very nicely from the previous talks. I don't know if any of you saw this editorial by Henrik Kellett in JAMA recently, criticizing in a way the adoption of enhanced recovery in the US, saying the addition of new and often inadequately studied drugs and interventions make it impossible to determine the actual incremental effect or benefit. I think this is very relevant to a lot of these blocks. As we said, there isn't that much evidence. And I think the onus is on us to do studies, whether they're randomized controlled trials or just collecting our own data to study these blocks. And I tend to take the mick out of some of our regional anesthesia colleagues, and I say it's very much become sort of see one, do one, tweet one in terms of local anesthetic blocks. And the other thing that I like to talk to them about is that you can describe a new block as long as it's at least 1 centimeter away from a previously described block. Hence we have QL1, QL2, QL3. I'm expecting to see QL55 tweeted soon. But I think this is important. We have to study what we do, and I'll show you some simple studies later on in the talk. So obviously I can't talk about intraoperative analgesia in total. Just to pick a few points that I think are relevant from our Poki papers. Nonsteroidals we've already talked about, and anastomotic leak. This is the comment that we made in our manuscript. Although there is concern, the literature is not conclusive, and there's insufficient evidence to recommend against the routine use of nonsteroidals. And I'll show you our pathways later on. We tend to use celecoxib up front. Gabapentinoids haven't been mentioned. I think it's worth mentioning. And there are several meta-analyses showing that they do decrease opioid consumption, and they can be part of your multimodal technique. However, again, you have to be a little bit cautious. They can be associated with respiratory depression, particularly with opioids. So when we give them, it's very much with a opioid minimization or sometimes no opioid technique. I would have caution if you're using them with opioids, and I'd also have caution in your elderly patients. Intravenous lidocaine, there's a number of good body of evidence that it can reduce opioid consumption. We use it particularly for our spine surgery. We use it for some abdominal surgery that's not having blocks. Some centers use it post-operatively for up to 24 hours. We can use it on the floor, but we're cautious because it means the patient, particularly with enhanced recovery, is tied up to an IV. So again, spine surgery, for instance, we would, but we don't. It's not our primary technique for our major abdominal surgery enhanced recovery pathways. The same for ketamine. Ketamine, again, highly effective, low-dose ketamine, 0.25 milligrams per kilogram per hour, particularly in the chronic opioid patients recommended. Again, can be used post-operatively, but the concern is that patients are going to be hooked up to that IV and may reduce mobilization. So what about blocks? This is a nice study from the UK, and interestingly, I've done quite a few talks on this same subject in the UK, and spinals with intrathecal opioid is the commonest technique there in laparoscopic colectomy. Here, I think undoubtedly it's Taplocks. This is a nice study comparing epidurals, spinals, and PCA. Again, relatively simple. You can see the PCA had the highest pain score, not surprisingly. The spinals and epidurals were comparable. However, when they looked at the length of stay, they find that it was longest in the epidural group. The length of stay is getting so reduced now in laparoscopic colectomy down to 1 to 2 days that epidurals can actually delay discharge, make mobilization harder. You have to transition them off the epidural, and that's why I think epidurals have largely gone out of favor in laparoscopic surgery. Taplocks, I know we've had an excellent talk. I'd just like to highlight how you can simply do studies. This study happens to be from where I trained in the UK, but I like it because it was just very simple. They randomized patients to either a Taplock, and they just did a posterior block, and I think that's important, or control. And the anesthesia team left the anesthesia room. A blinded team came in, either did the Taplocks or a sham, put some bandages on, and then they went through the surgery. And importantly, the primary outcome is not pain scores, which are so variable. It is 24-hour morphine consumption. And as you see, they saw a significant consumption just with reduction, just with 68 patients, and no difference in pain scores. And that's typically what you'll do, because patients use the amount of morphine that they need to get down to the pain score that they're comfortable. So you'll see the difference in morphine consumption, no difference in pain scores. Again, you've heard a little bit about surgical Taplocks. I'm, again, of the agreement. I don't think it matters who does the block. It's whoever's the best person to do the block at your institution. At our place, Julie does her own block. Some of the other colorectal surgeons, we do the blocks. So these are our pathways, just to show you an example. It's not saying this is right or wrong, but this is what we do at our institution. For our open procedures, just for completeness, the celecoxib gabapentin, we use the epidural. The percentage of bupivacaine has reduced over the years, so we now use 0.0625% to try and avoid that hypotension. Single shot dose of IV acetaminophen at the end, and then round the clock ibuprofen, gabapentin, and acetaminophen. For our laparoscopics, we couldn't decide whether to do a spinal or do Taplock, so we ended up doing both. So celecoxib gabapentin, we do a spinal at the front, again, very specifically say no intraoperative opioids, and then we can do the Taplock. At our institution, we do it at the end because we already got the spinal on board, and again, round the clock ibuprofen, that should be gabapentin and acetaminophen. Quick plug for our latest Poki, which occurred fairly recently in Vanderbilt, just been published online now, specifically looking at management of chronic opioid patients and the evidence for opioid-free anesthesia. And again, we'll be delighted to see you in DC. Thank you very much.
Tim.